everyone. Welcome to our fourth session of the ABCS of Heart Health Structured Collaborative. My name is Andrea Boucher. I'll be your presenter for today. And what we're going to focus on today is tobacco cessation. So while everyone is coming in and getting situated, we'll have you enter your name, title, and organization in the chat box. As well as something that, back in slides, something that you have implemented from the topics that we've discussed in our previous session so far. So as a reminder, our previous sessions have covered topics of self-measured blood pressure, aspirin use, and cholesterol management. So if you've implemented anything from those sessions so far, we would love to hear what you've been working on. But I'll just go through a couple of housekeeping items before we dive into our content for today. So all of our sessions are recorded. We do hope that you're able to attend with us at each session, but if you're not, we do have the recordings available for you. If you are able to mute yourself when you're not speaking, we really appreciate that, but we do want to make this session interactive, so feel free to jump in with any questions you might have. You can also use the chat function as well, so put that information in there. And like I said, making this session interactive, we would like to see your smiling faces. So if you have a camera and can turn it on, we would love to see you and would appreciate that. So I'll go in the chat box and just check in to see who is all here with us today. So welcome everyone. And if you did implement anything over the past few weeks or months since you've been joining us on this collaborative, we would love to hear what you're working on. And Carrie has put our pre-assessment in the chat box as well. So if you could please take a moment and click on that. And it's just a few questions. Would love to have you fill that out related to the information that we will be sharing today. All right, so just a reminder on our collaborative schedule, we have one session left where we will be covering cardiac rehabilitation. And that will be on June 4th. So as a reminder, we do meet on the first Tuesday of each month from 12 to 1 Central, 1 to 2 Eastern. So we hope that you'll be joining us for our last session next month. All right, so I will go ahead and dive into our content on tobacco cessation for today. The content for this session is provided by the RX for Change program. And what we're going to be talking about is the epidemiology of tobacco and nicotine addiction and how to assess a patient's readiness to quit. So why should clinicians address tobacco? We know that tobacco use is a complex, it's an addictive behavior, and really helping a patient to quit requires not just drugs or medications, but also behavioral intervention. As clinicians, we look to clinicians as educators who are routinely interacting with patients to work on health-related issues. And as patients who are tobacco users, they expect to be encouraged to quit by health professionals. It's kind of a known when you're going into a doctor's office to be talked to about tobacco use. A clinician who does not address tobacco use during a clinical encounter is almost implicitly implying that quitting might not be important. So we want to make sure that this is addressed with every patient at every visit. There's a lot of health benefits that can be seen over a span of time after a patient quits tobacco. So diving into this, if you look at the health benefits at 2 weeks to 3 months after quitting, a patient's blood circulation improves, walking becomes easier, and lung function increases as well. From 1 to 9 months later, the lung ciliary function is restored. There's a greatly amount of decrease in the chance of infection because the lung environment is not as susceptible to bacterial growth, not as much coughing, sinus congestion, fatigue, shortness of breath. All of those symptoms decrease at that time. Looking at someone who has quit tobacco use after a year, there is a decreased risk for coronary disease, and that comes down to that of half of what someone who has continued to smoke would experience. After 5 to 15 years, the stroke risk for patients is reduced to a rate that's similar to people who have never smoked. At 10 years after quitting, an individual's chance of dying of lung cancer is approximately half of that as someone who has continued to smoke. Additionally, their chance of getting mouth, throat, esophagus, bladder, kidney, or pancreatic cancer is also decreased. And then lastly, 15 years after quitting, an individual's risk of coronary heart disease is reduced to a rate that is similar to that of people who have never smoked. So we obviously see that these benefits of quitting are pretty significant. So really emphasizing that it's never too late to quit, and it's never too late to really reap those benefits of quitting. So this slide shows the results from a study that looked at the hazards of cigarette smoking in those who formed their smoking habits at different ages, different periods in life, and how the reduction in risk when cigarette smoking was stopped at different ages. So if someone were to quit at ages 30, 40, 50, and 60, what they were seeing was a 10, 9, 6, and 3 years of life gained, respectively. So as you can see, the earlier in life that you stop cigarette use, the more years of life gained. So on average, cigarette smokers are dying approximately 10 years younger than non-smokers do, and those who continue smoking, at least half of those will die due to a tobacco-related disease. People who quit before the age of 35 and will add 10 years of life and have a life expectancy similar to people who have never smoked. So obviously there's a lot of health benefits of quitting. We can also see financial benefits of quitting as well. The financial costs of tobacco use can really be pretty substantial, particularly when the costs are accrued over a lifetime or across many years of use. So this slide shows what 3 levels of smokers who buy cigarettes every day for 50 years, the cost that they would incur. This is assuming that the cost of a pack of cigarettes is $7.19. That's based off of 2020 data, where instead they could have, saved this money if they did not have cigarette use. So in 2020, the annual cost of someone smoking cigarettes, a pack a day, was $2,624. Kind of breaking it down into each of our respective states. In Michigan, the current cigarette prices are at about $6.44. And kind of taking a look at the usage of tobacco in Michigan, it's actually pretty high. It's at 18.7%. In Minnesota, Minnesotans spend approximately $873 a year if they were to smoke about 2 packs per week. But Minnesota is actually one of the destinations that have the most expensive cigarettes in the US, which may be a contribution to why the tobacco use is not as high. It's at 14.6%. And then lastly, in the state of Wisconsin, about 15.4% of adults use cigarette products. So that rate for the cost of cigarettes in Wisconsin is $7.67. So you can see there's a little bit of variability across our 3 states in both usage of tobacco and cigarettes and the cost as well. But as healthcare providers, there's really this professional obligation to help patients improve their health overall. That does include addressing tobacco. Oops, sorry, jumping ahead here. And really to helping patients quit their tobacco use. So clinicians are really this facilitator of the process to helping patients quit, helping call attention to the patient's need to quit, advising them to quit if they are in need of assistance with a quit attempt, and really monitoring their progress over time. It's been said that tobacco users don't plan to fail in their quit attempts, but most fail to plan. So for current tobacco users, the goal is to really move them forward in their decision to quit, depending on where they are in that process. But that decision to quit is really ultimately lying in the hands of the patient. So what are tobacco quit lines? Really want to emphasize that clinicians don't have to tackle tobacco cessation alone. There's a lot of resources like the tobacco quit lines that can help with that. Sorry, I'm just going to flick through a couple of these real quick. Tobacco quit lines are telephone services. They provide tobacco cessation counseling at no cost to the caller. Quit lines have really seen an increase over the last decade. They provide comprehensive interventions that can help to reach patients who might not otherwise have access to those resources. Maybe they are experiencing barrier based on their geographic location, maybe a lack of insurance or financial resources to receive assistance. So quit lines are a great resource from that perspective. Also, there are some quit lines that offer medication along with the behavioral counseling, which can assist with that. What's been seen is with patients who have behavioral counseling, their abstinence rates are significantly higher than those who are actually just on medication alone. So the telephone number for tobacco-free quit lines are 1-800-QUIT-NOW. In some states, clinicians can do a fax referral form on behalf of the patient and send that to the quit line to initiate that process. In that way, a quit line counselor is going to contact the patient directly. And there's really about a 30% success rate for patients who have completed their follow-up sessions with the quit line counselors. But most physicians, most smokers or tobacco users don't know about quit lines. So they're really underutilized by most smokers who want to quit or are thinking about quitting. So even if our busiest clinicians can really play an important role simply by identifying those tobacco users and referring them to a quit line and the services that are offered there. So when a patient calls the quit line, the counselor or the intake specialist is going to answer that call. In most states, the counseling is available in more than one language, and the caller is routed to an appropriate staff member based on what their needs are. So they'll typically complete a brief questionnaire. They'll be assessed based on their contact and their demographic information, what their smoking behaviors are, and what type of services they are looking for. In most states, the quit line can refer the callers to local programs. They also have the availability to send resources through mail, and then again, providing those individualized telephone counseling behavioral services as well. So this is a really great resource that is available for providers to refer to and patients to capitalize on as well. But making tobacco cessation a priority in practice really takes commitment. It's recommended that all clinicians make a commitment to incorporate that brief tobacco intervention as part of their routine care with all patients. So you can really successfully do this in about 5 minutes, and this can be done in that regular interaction with the patient. Clinicians should ask the patients about their patient's tobacco use, advise patients to quit, and then refer patients to other resources for additional assistance. So this is known as the Ask, Advise, Refer, or the AAR model. So one question that comes up is, what happens if a patient asks you whether you use tobacco or maybe have used tobacco in the past? So this is where it's really important to be honest. If you've never been a tobacco user, sometimes it can be difficult to understand how hard it can be for some patients to quit. But being a healthcare provider, you understand what the physiologic and the psychological nature of addiction is, so that can help provide some insight into a patient's experience. And as clinicians, we want to counsel patients for all types of diseases without having the diseases themselves. So you don't always have to have that lived experience, but it's appropriate to admit when you don't have that lived experience. You might not have personally dealt with quitting yourself, but maybe you've worked with a lot of patients who have. So acknowledging that is a really important part of the process. If you have been a tobacco user or maybe are a current user, you probably have some better insight into the meaning of tobacco dependence. Maybe you've tried to quit before, maybe you were successful, maybe not. But here is where it's important to assume that or to not assume that patients' experiences are going to be similar as yours as far as quitting. It can be helpful to provide some of that lived experience of, this is what happened to me and giving that insight, but trying to not express it in a, I did it, so you can do it too kind of attitude. We want to make sure that, we're being sensitive in our approach and dealing with patients on an individual basis. Often some of the best tobacco cessation counselors are people who may have had that experience with tobacco use. And if you are a current user, it is really strongly encouraged that you do quit and you are able to kind of use that experience in working with patients. All right, so prior to providing assistance with tobacco cessation, it's really important to assess where a patient is at in their readiness to quit. So when people need to make any kind of health behavior change, it's really not going to be a very spontaneous decision. It's something that is going to take time. Change is really a process. There are 5 stages in this overall process of behavior change. And again, these stages apply to many behaviors, not just with tobacco use. So the first one is pre-contemplation. So this is when someone is not thinking about making the change within the next 6 months. Contemplation is when you're considering changing within the next 6 months, but not within those immediate next 30 days. Preparation is you're ready for change in the next month. Action is you're in the process of change, but you've implemented the change less than 6 months ago. Maintenance is when you fully implemented the change for more than 6 months. So that action stage is where that behavior change is going to take place. That is going to be the first step for most patients. So in most cases, other stages have to be successfully transversed. You have to move through these stages before action can occur. So if we're looking at smokers specifically, about 50 to 60% of patients are going to fall in that contemplation stage. We'll see about 30 to 40% in contemplation, and really only about 10 to 15% are in that preparation stage. So they're, getting ready to do this change within the next month. So the amount of time that is spent within each stage is going to vary by patient. So assessing that readiness is going to help clinicians to understand what counseling and messaging interventions might be appropriate for that patient. So the goal at each stage, at any point, is to really move a patient forward. So helping them to develop that readiness for permanent change. Patients in different stages, again, they're going to require different interventions. For example, someone who is in pre-contemplation might need a very different type of intervention than someone who is in the action stage, someone who has already quit smoking. So determining each patient's stage is going to save you a lot of time by making sure that that intervention is appropriate and that the patient's needs are going to be met with that intervention. So again, this diagram on this slide is really just a visual representation that behavior change is a process. So over time, the patients are going to cycle through in and out of these different stages. They might quit for a while, might return to tobacco use before they quit again for good. So that movement between these stages is normal. It's to be expected. Particularly for behaviors such as tobacco use, which is an addictive behavior. Patients know that they need to stop, but maybe they don't have the time or energy or will to stop at the present moment. So for that reason, it's really important to determine readiness to commit. So also we want to make sure we're not assuming that patients who inquire about quitting are actually ready to quit. So maybe they're in that contemplation or even that preparation stage, they're thinking about it, they're gathering that information, but not assuming that a patient who asks for that information is going to actively quit within the next 30 days. Also not assuming that a patient who asks for a prescription for a nicotine replacement therapy or even goes to the pharmacy to buy those medications is ready to quit. Maybe they're just still in that contemplation or preparation phase. It's really helpful here to get that better understanding of why it's important to think about behavior change as a process and an ongoing process, not just a one-time event. This slide is a flow chart that describes how to determine a patient's readiness to quit, the different types of interventions that should be applied. I won't spend too much time on this, but really focusing on the treatment side of things for patients who are ready to quit and do fall in that preparation stage. So the left-hand side of this slide, those should always include the 5 key counseling components, or the 5 A's intervention. We have a lot of other resources about that, so won't go into that today, but this is just kind of a visual depiction of how you can kind of plot out where a patient might be in the stages of change. So breaking down each stage, when we're looking at these specifically in assessing a patient's readiness to quit, that first stage is going to be pre-contemplation. So this is when patients are not considering making change in the foreseeable future. Again, usually that's defined as the next 6 months. Typically, patients here fall into 2 different categories. The first one being those that are not aware of any need to change. Maybe they just don't even have this problem on their radar at all. And then the second one being those who are unwilling, or maybe they're unable to change. So maybe these types of people are a little defensive about their health behavior. Maybe they're feeling discouraged right now. Maybe they've had prior quit attempts that were not successful. So healthcare providers commonly label patients in this stage of change either as difficult or unmotivated. Many of these patients are just simply not ready. Maybe they're struggling with ambivalence. They see more of the pros or the positives of tobacco use, and those are seen as more important than the cons or the negatives of their tobacco use. So really the goal of intervention at this stage is to move patients into contemplation. If a patient's ready to move to the action stage at this point, it's important not to discourage that, but patients should not be forced to move too quickly or more quickly than they're comfortable with at this point. So counseling a patient who is in this stage, you really want to demonstrate understanding, demonstrate empathy, make sure you're fostering ongoing communication, and asking non-invasive questions. This is really helpful. So instead of pressuring the patient into that more immediate behavioral shift, it's kind of giving that gentle guidance and giving the patient more awareness of what the health consequences are of their continued tobacco use. Here, it's important to use messages that emphasize the cons of tobacco use, or de-emphasizing what the pros are, to help that patient see what those cons are and move them forward in their change process. Here, it's helpful to tailor messages to specific patients, maybe highlight how tobacco use can impact any particular disease that they're already dealing with. Maybe it could exacerbate some existing conditions. That could be helpful in highlighting that for some patients. Also, an approach that might be helpful for parents, talking about how smoking could negatively affect their children's health, that their children will grow up to be smokers. So really strongly encouraging patients to quit, but emphasizing that the decision to quit or even to not quit is ultimately up to the patient. You can also gauge a patient's level of resisting to quit by asking questions, for example, if I were to give you an envelope, what would the message inside need to say for you to consider quitting? So if the patient responds back and says, there's nothing that you could say or write in there that would make me consider quitting, then there's probably not a whole lot you can do at that point, except to, 1, stress the importance of quitting for the patient's health, 2, suggest that the patient may not rule out the possibility of quitting in the future, and then 3, offering assistance with quitting if the patient changes their mind. Here, it's important to not be aggressive in using persuasion to make a change. That high-spirited kind of cheerleading aspect can only heighten a patient's resistance at this stage. So it's important to be careful not to be judgmental in telling the patient that, just saying that tobacco is bad for you. It's not going to be time to provide a treatment plan at this point either. it might be useful to inform patients of the various options that they have available. And again, kind of putting the ball in their court, allowing them to make that decision. Ultimately, it comes down to offering assistance, make it clear that that's, an ongoing standing offer, open and available to them when the patient is ready. The second stage in the continuum is going to be contemplation. So during this stage, patients are considering taking steps to change their behavior in the near future. This is within the next 6 months. They recognize that need to change. So they are aware of the benefits of changing, but maybe they're going through that struggle, that ambivalence about that behavior change. Patients in this stage are going to be more interested in talking about quitting than those who are in the pre-contemplation stage. They may be more receptive to offers of assistance to quit. But maybe these patients express a little bit of guilt or shame about their inability to quit. Tobacco use it can be a very stigmatized behavior. People are very aware of the negative health consequences of tobacco use. So in that case, many tobacco users are in that contemplation stage already because it's so, there's a lot of information out there about the negative health impacts of tobacco. So they know that they need to quit. They already are thinking about it, but maybe they're just not ready, or maybe not able to commit to a quit attempt at this time. So there are some do's and don'ts in the contemplation stage. Really to do is to provide information, education about what's available to the patient, and some quitting resources and how you can more broadly help them in the quit process. Strongly advising the patient to quit. Taking a look at what the patient's reasons are for their continued tobacco use, why they may not be ready to quit at this time. Demonstrating empathy is also really important here, especially if the patient is struggling with their motivation to quit. Expressing optimism in your ability to make the patient's next quit attempt successful. So what can you do as part of their care team to help them quit? Encouraging the patient to reevaluate what their concerns are about prolonged use. So bringing those issues to the forefront could help patients move forward in their readiness to quit. Although a patient in the contemplation stage might be closer to making that behavioral shift than one who's in the pre-contemplation stage, it still is a little bit early to attempt any action-oriented interventions at this point. We want to make sure that those are appropriately timed, that the patient is ready, and that they're equipped to go into that action stage. So the same don'ts from that pre-contemplation stage actually apply here as well. But many patients are kind of chronic contemplators. They really consider quitting, but don't really act on it. So while they're considering that behavior change, they're looking for new information, they're looking for strategies, suggestions, but they feel that might, reducing their struggle might prevent them from making a quit attempt. For the chronic contemplators, here it's helpful to make small steps in helping them make that behavior change, moving them towards that preparation stage. So here you could recommend that, maybe they delay their first cigarette in the morning by 30 minutes, cutting down on the number of cigarettes that they smoke per day, or even could they go 24 hours without smoking? So, not making those big drastic steps of quitting completely, but what are those small steps that they can take to have a successful quit attempt? So for patients who are not ready to quit, we really want to make sure that they are encouraged to seriously to consider quitting by asking a series of questions. So the first one is, do you ever plan to quit? So most patients will hopefully respond yes, which in that case you can go on to number 2. But if they say no, that they don't plan to quit, then here is where you want to strongly advise those patients to quit, offer that assistance, and make sure, you're there, they know that you're there to help them should they change their mind. If they did say yes, then you can ask, what might be some of the benefits of quitting now instead of later? So the longer a patient smokes, quitting is generally going to become more difficult. Most patients are going to agree that, there's never really an ideal time to quit. Procrastinating on a quit date is going to really have more negative effects than positive. And then the third question is, what would have to change for you to quit sooner? So this question really gets to the patient's perceptions of quitting. Maybe that's going to reveal some of those barriers that they may have to quitting, and then those can open up for further discussion too. So the third stage in the continuum of change is preparation. Patients in this preparation stage are going to be ready to quit in the next 30 days. These patients recognize that there is a need to change. They know what the benefits are of quitting. They're getting ready to take action. Maybe they've made a quit attempt in the past year. So for patients in this stage, really the cons of their tobacco use are going to start outweighing the pros. So they generally have more confidence in their ability to quit than patients might have in those pre-contemplation or contemplation stages. So the goal here is going to assist these patients in achieving cessation. So 3 key elements of tobacco cessation counseling are going to be assessing tobacco use history, discussing key issues. These are important. So this is really more of the information gathering steps of counseling. It's helpful to have clinicians develop that understanding of patients' unique history, what the patient's perspective on tobacco use is before starting and helping with that quitting process. And then that last step is facilitating the quitting process, including that practical counseling, whether that's problem solving skills or skills training and social support. Those can all be as part of the patient's treatment. So this stage is really representative of a window of opportunity for helping a patient make a quit attempt. Before making any treatment recommendations, there's some steps that need to be done. The first is really to praise the patient's readiness to quit. Give them the confidence that they can do it. Again, assessing tobacco use history, taking a look at, what's the current use of tobacco? Are there different types of tobacco that are used? How much is used? What is a patient's past use of tobacco? So how long has the patient been using tobacco? Has the patient changed his or her level of tobacco use recently? Maybe they're using a lot less than they had before. What are their past quit attempts? How many quit attempts have they had? How long were they off tobacco use? When was their last quit attempt? And really diving into what methods were used. This way you can understand what worked, what didn't work. If there were medications that were used, how were they used? Were there factors that contributed to relapse? So maybe there were some triggers that kind of made the patient relapse. So identifying those reasons can really give a good picture of what might be important for an upcoming quit attempt. The preparation stage is where you want to address any of those key issues. Again, those reasons and motivations for wanting to quit, asking the patient to think about the why. So what is important to them to adopt a tobacco-free lifestyle? Also looking at confidence level. Is the patient confident in their ability to quit? The patient will hopefully be highly confident, but many are going to lack that confidence because of failed attempts in the past. So providing additional support, working with the patient in designing their treatment plan, making sure it is individualized. Clinicians can help really instill confidence into patients, helping the patient understand, it can be different this time because the patient will be more prepared. Talking about any specific triggers for tobacco use. Triggers could be, being around other smokers. Are there certain meals where they would typically use tobacco? If they're around any alcohol or maybe coffee consumption, identifying any cravings that they might have for tobacco. Maybe they're under time constraints and that causes a level of stress. So those triggers should be identified prior to quitting. while the patient is still smoking kind of in their quote unquote normal use, so that you understand what they might need to help them quit. Encouraging patients to think about the times and places where they smoke or use tobacco and each time that they do. Again, that gives you that clear understanding of the behavior, so that will help the person to be more effective in their quitting attempt. Determining whether there are certain routines or situations that the patient associates with tobacco use. Again, maybe it's driving in a car, drinking coffee, maybe they're bored or stressed or after meals. What are those certain routines where they are using tobacco? Do they use it in response to stress? What are some of those triggers that invoke stress-related tobacco use? Assessing whether the patient has a social network, friends, family, coworkers that are supportive of their quit attempts. Encouraging the patients to enlist those in their network that can be supportive of them, and inviting them to maybe attend some of their cessation counseling sessions. Assessing whether the patient is concerned about post-cessation weight gain. If the patient has any concerns about this, you really want to make sure that you are able to provide them resources and assistance. If they are concerned that this is a barrier for them quitting, you want to make sure that that is addressed simultaneously with that quit attempt. So you're working on both of those things. And then lastly, discussing any concerns that the patient might have about withdrawal symptoms. So again, talking about stress, this is oftentimes cited as the most common reason for smoking. This slide kind of outlines what the myths versus the facts are. Smokers often confuse that relief of their nicotine withdrawal with this feeling of relaxation. So some common comments are that smoking gets rid of all my stress. I can't relax without a cigarette. So really the facts here are, there's always going to be stress in one's life. Cigarette use is not going to get rid of one's stress, but there are a lot of different ways to relax or to manage stress without the use of a cigarette. Really, the goal here is to help patients realize that tobacco is the problem, not the solution. So when you're facilitating the quitting process, clinicians should talk about, again, the pros and cons, and looking at the pros and cons of the methods for quitting. Really, it's important to get the patient's point of view, what is going to work for that individual patient, because they're going to have their own perceptions on these different methods. You can encourage the use of pharmacotherapy in addition to behavioral counseling. Many patients might feel that pharmacotherapy, they might view it as like a crutch. These patients should be advised that tobacco use is a chronic condition. It alters brain chemistry, and sometimes pharmacotherapy should be used because that does increase the chance of quitting. So that can be viewed as a treatment, not as a crutch, and to really kind of communicate that as such. Helping the patient set a quit date. So if you're really looking at when this should be, looking at least 3 days out, but not longer than 2 weeks from the current day. One thing that's helpful to do before setting the quit date is using a tobacco log. So this helps the patient understand what moods or activities or situations they might have experienced that trigger that desire to smoke or use other forms of tobacco. So those triggers should be identified before quitting. It's really helpful to understand that the patient knows what to look for in their quit attempt. So information can be gathered in that log and used to develop some coping strategies to overcome if there is any temptation to use tobacco. The fourth stage is action. So this is where the patient has quit using tobacco sometime in the past 6 months. These patients are taking the steps necessary to enhance the likelihood that they're going to have a successful quit attempt. Maybe they're using medications like nicotine replacement therapy. Maybe they've disposed of unused cigarettes. They've taken lighters out of their home, their car. wherever they might typically use cigarettes. So they've really altered those routines and kind of removed those habitual patterns so they don't have any temptations. Here, patients are likely experiencing changes, maybe some withdrawal symptoms. Some are going to be pleasant. Maybe they have some revived taste buds back. Some maybe not so pleasant. So some cravings, irritability, weight gain. So here, those recent quitters are really at high risk for relapse. The goal here is to help these patients remain tobacco-free. So those recent quitters are going to be facing a lot of challenges in adopting that new behavior. During their quit attempt, you want to make sure you're carefully tailoring those interventions to match each patient's need. So there's some basic strategies that you can use to evaluate a patient's quit attempt. Again, inquiring about available social support. So what family, friends, coworkers do they have that can help them in this process? Identifying temptations and triggers that could trigger relapse, suggesting those coping strategies that you've hopefully identified in advance as needed, removing any of those cues in their environment that could make them want to use tobacco, like their ashtrays, not into an office if they have, a lot of colleagues who smoke that are congregating outside the office. Encouraging healthful behaviors to replace smoking. So maybe that's, drinking more water or exercise, giving them some other ideas on how they can replace that. Determining whether the patient has had any slips or relapses. And then lastly, evaluating the treatment regimen. So were they prescribed any medications? Are those medications adequate? Are there any withdrawal symptoms that they're experiencing? So how can the pharmacotherapy be terminated? When should that happen? So relapse prevention is an important component of tobacco cessation interventions. This should be really part of every encounter with patients who are recent tobacco quitters. At a minimum, the quitter should be congratulated for their success and really strongly encouraged to remain tobacco-free. Relapse prevention interventions should include talking with patients about their perceived benefits of quitting, what challenges have they come across during this process, what successes have they had, potential barriers to continued abstinence. So for patients who are feeling maybe a sense of loss after quitting, maybe they feel like in this process they felt like they lost a best friend. Acknowledge those feelings. Make sure that those patients feel reassured. Those feelings will subside over time. Identify and recommend other activities that particular patient can view as rewarding. And then assessing the patient's level of ongoing support for the quit attempt. Here you can schedule follow-up visits or calls as needed to prevent relapse, and if it's necessary, refer them to any external tobacco cessation in the community. And the final stage of the continuum is maintenance. So patients in this stage have been tobacco-free for at least 6 months, but nevertheless, they are still vulnerable to relapse at this point. So the strategies that are to be applied for these patients are similar to, but maybe a little less intense than those in the action stage. So the goals for these patients to remain tobacco-free for life. So similar to those recent quitters, clinicians must evaluate the status of their quit attempt, even though it's been 6 months or longer. Has the patient had any strong temptations to use tobacco, any occasional tobacco use, even if it's just a puff? You really want to make sure that is, it's okay to talk about that. Also, it's important to ensure that patients are appropriately terminating or tapering off those pharmacotherapy products when it's appropriate. Relapse prevention strategies should be discussed as needed. Healthy behaviors should be encouraged, ones that patients don't associate with tobacco use. Again, exercising, coming up with different hobbies, maybe more hobbies that are involving the use of hands. So to reduce any weight gain, it's important for patients to also maintain a healthy diet. Again, making sure that that's coinciding with their quit attempt, that you're working on both of these at the same time. And finally, patients who've been off tobacco for 6 or more months should be congratulated. That is an enormous success, something they should definitely be proud of. Staying tobacco-free is, again, a continuous process. And as clinicians, acknowledging, rewarding, reinforcing those patients' triumphs in the face of challenge is really important, and that patient feels that recognition. And also the availability to continue to assist throughout that quit attempt. This is going to be, again, an ongoing process. So providing that ongoing support is important as well. So with that, we covered a lot about tobacco cessation today. I will go ahead and pause. If there are any questions, you can feel free to unmute and ask a question or add it in chat. And as we're waiting for questions to come in, Carrie has put the link to today's presentation. The slides are in the chat, so if you're looking to access those, they are available to you there.
Hi, this is Margaret from WASA. I apologize. I somehow got the invite, so I've joined late. So you may have already addressed this, but I just wondered if there has been any thought to the vaping side of nicotine use that way, or if how that applies or fits in with this as well.
Absolutely. Great question, Margaret. I think that's a something that can definitely be applied. You can use these behavior change methods in talking with patients about vaping as well. There's some resources out there on the use of vaping that we can definitely provide to you as well. But yeah, it's kind of similar to the 5A's resources that we have out there for quitting tobacco. So I think, yes, absolutely, still applies as a behavior change and something you would want to encourage patients to kind of move towards not using vaping as well.
And I was going to say, thank you, Margaret. That's a great, as Andrea said, that is a great question about the vaping. We also understand too that they're, because this is about tobacco products, it's not just the cigarettes, it's also about, people using too. And I can't remember, Carrie taught us about a new project that some of the younger men are using. I forget the name.
It's
Now,
ZINS, ZINS. Some of the younger kids are using it's a nicotine product that comes in a pouch that they use in like chewing tobacco, but it's in a pouch.
So I just was thinking too, I'm sure all of you are doing this when you are talking to your patients about their tobacco use. Just sometimes I think patients maybe had the belief that if they're not smoking a cigarette, or, I think we were led to believe that vaping was safe. And so I think it's kind of helping everybody the patients understand too, it's not just cigarettes, it's across the board, anything with nicotine in it, and how hard it is actually to be quitting that nicotine product.
Yes, absolutely. Thanks, Jerry. Any other questions? Okay. Hearing none, we have a couple of final housekeeping items we wanted to make sure we covered before we wrap up for today. So if you remember at the beginning of this series, we talked about providing blood pressure devices for self-monitoring programs to those who attended all of our sessions with us. So we are going to begin that process between now and our next session. So if you are meeting those requirements, we will be reaching out to you and working on getting these blood pressure devices ordered and in your hands. So just wanted to make you aware of that process that will be happening between now and our last session. And moving forward after that, we are very interested in assisting you and providing some one-on-one technical assistance, especially on a monthly basis as we move this forward, and hopefully you can get some self-measured blood pressure programs off the ground if you don't have one already. So we will be reaching out to you and hopefully scheduling some time to provide assistance related to all the topics that we've covered in this session, in these series here, and in particular related to the self-measured blood pressure devices. Superior Health team, was there anything else anyone wanted to add for next steps? Okay, got that covered. Oh, go ahead, Mary.
Yes. So slow getting off mute. And we'll cover more of this too in our final session on June 4th, but just a little bit too about the one-to-one technical assistance, and then just with the blood pressure cuffs, probably looking for some data and feedback from you with the use of those cuffs. But we'll talk more about that next session. So I just want to make sure that everybody attends next month on June 4th.
Thank you, Jerry. Yeah, final reminder, we do have our last session, June 4th, on cardiac rehabilitation. So again, we hope to see you there. And just some final reminders, we do have a lot of great information out on Superior Health Connect. If you haven't joined us on there yet, the link to do that is on this slide. So you can access that from the slides that Carrie had put in the chat. So we'd love to have you join us on there. And we do have some other Superior Health services that are available to you as well. We have some on-site mobile vaccination clinics and health fairs. We cover providing education to patients. So if you are interested in learning more about this, you can reach out to immunizations@superiorhealthqa.org. There's also a link to the health fair request on this slide. So if that's something that is of interest to you, we would love to be able to come out to your community and provide your organization and the patients that you serve with these services. But with that, that is all that we have for you today. So again, we hope to see you at our last session next month, and we will be reaching out in regards to the blood pressure devices. So thank you, everyone. Have a great rest of your Tuesday.